This is the first session on carotid. It gives me the privilege to introduce Professor Ali Aburahma. He is Professor of Vascular Surgery in West Virginia, United States, and the former president of the Vascular Society of the United States, the head of the Vascular Society in the United States. He will give us a presentation on carotid screening indicated, general population versus high-risk patients.
Good morning, ladies and gentlemen. I'm honored to be among you again for the third or fourth consecutive years, my second home of Egypt. There is nothing to disclose on this presentation, and first talk really try to answer a question which we put as, if you notice here at the up corner, question number 4, that's what was brought to our attention as the writing group for the carotid guidelines of the SVS, which was published a little bit over 2 years ago. The question was, is screening asymptomatic carotid stenosis recommended in the general population? And we followed what we call the scientific method of PICO, patient, intervention, comparison, and outcome, and of course, study design, if there is any study design related to this. What was the evidence when we look into the literature? There is no consensus has been reached on which patient population should undergo carotid screening, knowing for asymptomatic patient, knowing the fact it's extremely common practice in the United States. Some people even go with their machines to malls, to shops, to churches, and done almost every day around the country. However, there is no really scientific evidence to prove is it appropriate or not. No direct evidence available on the benefit of screening regarding actual outcome of future stroke. The rationale behind screening for asymptomatic disease has been determined by the assumption that unheralded stroke is often the first symptom of significant disease. Therefore, intervention may prevent future stroke. Screening found to decrease risk of stroke in cost-effective method if prevalence of the disease is roughly in the range of 20%. And there is data to show or confirm this number, roughly 20%. With prevalence of less than 5% in almost all studies, whether Western world or Eastern world, in general population, presence of significant carotid disease in general, if you screen everybody, is less than 5%. Therefore, to us, we believe it was harmful and lead to inappropriate intervention which might not need to be done. That position is supported by multiple professional organizations, not just the Society of Vascular Surgery, but National Stroke Association, the American Heart, Canadian Stroke, and United States Preventive Task Force for Screening. With that in mind, we came out with this recommendation, which we gave it as grade 1B, recommended against any routine screening for clinically asymptomatic carotid stenosis in the absence of cerebrovascular significant risk factor for carotid disease. And that was published, as I told you, over roughly 2 years ago. Then we came out with the second part of the question. Is screening for carotid stenosis recommended for high-risk asymptomatic patients? And again, following PICO, and we put subgroups of various risk stratification for cardiovascular disease, including carotid disease. What is the evidence and rationale? If you notice here, looking to the slide on the right side, look here, it's on the left now, the prevalence of disease on top is little. You go to the bottom, it gets to be in much, much higher. For example, hypercholesteremias, look at the proportion of presence of significant disease is roughly 2%. Hypertension, roughly 2%, and so forth. Look in the middle, when we reach into patient with PAD, it jumped to 18%. When you put PAD and coronary artery disease, it's roughly around the same, but it go higher with PAD and smoking. So look into this number and add more risk factors, the prevalence become much more than 20%, which means based on our calculation, it become extremely variable. And based on that, we gave the following recommendation. In selected asymptomatic patient with increased risk of carotid stenosis, suggest clinical screening for clinically asymptomatic carotid disease if the following are there. And we gave it grade 2 and the level of evidence is a B. High risk group including patient with PAD, patient undergoing CABG, patient above 25 years old with at least 2 traditional atherosclerotic risk factors, above 55 and active cigarette smoker. Patient with diabetes, hypertension, coronary disease, or patient with clinically occult cerebral infarct, or if the presence of carotid bruit in addition to another risk factors, we felt probably we could give it also 2B grade. Then the question comes, is screening for carotid stenosis recommended for high-risk asymptomatic patients? The question right away, high risk for what? To do an intervention? If it is, if you notice, we gave it a 2B in selected specific type of patient who may benefit from the procedure. However, look to the European in contrast, they felt no, it should be done regardless whether they need intervention or not, because that gives the clinician a better way of monitoring what your patients are doing related to their risk stratification. They gave it same level, 2B, level B. So the rationale was a little bit different between the SVS and European SVS. Finally, this is the commonest, actually referred to all of you, including myself. Patient come to the family practitioner or general practitioner with asymptomatic carotid bruit, and then by referring to you. I just felt maybe to add a few slides related to this. We know carotid bruit means some hemodynamic instability, mean disturbance of flow. Therefore, maybe it's worth it. However, it was not specific or sensitive in a clinically significant carotid disease. Meta-analysis of studies describing relation between bruit and carotid stenosis actually did not show the exact effect. However, 28 prospective cohort study of over 17,000 were analyzed, and it shows stroke rate was 1.6 per 100 patients years for those with bruit versus 1.3 per 100 for those without bruit. So it was not really statistically significant if just looking to bruit alone. Therefore, the presence of carotid bruit likely increased the risk of cerebrovascular disease and may justify screening in some patients, otherwise they are asymptomatic. Other studies show higher number of carotid stenosis in patients with carotid bruit versus no carotid bruit. A patient had other atherosclerotic risk factors. Therefore, it's being proposed by some patients with previous radiotherapy, for example, should undergo screening, duplex evaluation in absence of clinical cerebrovascular disease, cerebrovascular symptoms. I jump to something, other risk factor of having significant disease with neck irradiation, for example. However, the time of irradiation to cause some type of narrowing vary between 5, 10, sometimes people even tell you up 15 years. Therefore, when do you start screening? The answer is up to now is not clear. So if you want to screen these people, probably should not start before the next 10, 15 years. The final item of screening, should we screen people who come to you with an aneurysm? To make it short for you, the answer is probably is not valid, because the incidence in the presence of patient with aneurysm is definitely much, much lower than the 20%. Therefore, we do not feel that it's important for us to screen people with abdominal aortic aneurysm. Thank you very much for listening.